it's really, really good to see a mix of students from different years. You are welcome. This is the 7th Clinical Associate Information Career Webinar. And we do these sessions because mostly we want to have an opportunity where students can come together and be able to hear from their seniors about the workplace, about the challenges, about the achievements, and just such wonderful paths that their seniors have taken. So hopefully you get some inspiration, some motivation from the sessions, but also be able to network later on if you want to follow up with one of the graduates and ask them some questions of interest. How the session will run, we're going to have guests who are going to have about 10 to 15 minutes just to share with you what has happened from the time of graduation to the current state. So first up, I am going to ask Nombasa to get ready. So Nombasa is a qualified clinical associate. She graduated from the University of Witwatersrand in 2020. So that's when COVID hit us. And she's got her 3 years worth of clinical experience. She's been working both in the public and the private sector. She's skilled in emergency and trauma medicine, and she's done several short courses to develop her skills. So that's from the Knowledge Hub, but also from De Novo Medica. Hopefully, she'll tell us more about that. So, such as the basic HIV and AIDS management, TB management, just to assist with also an approach to chronic patients, to name a few. So, over to you, Nombasa.
Good evening, colleagues. Good evening to all the students that are here. Good evening, Ms. Aviwe and everyone else. My name is Nombasa. I've created a presentation, so I'm going to head straight on to the presentation that I prepared. So I'm going to speak a little bit about my journey as a clinical associate. I'm still fairly new in the field. I've recently graduated, I think just during COVID in 2020, and I only have 3 years working experience. So my name is Nombasa Namba. As I mentioned, I'm a clinical associate graduate. I graduated in 2020 at the University of the Witwatersrand. My first job as a clinical associate was in a private sector at Netcare Pinehaven Hospital, which is in Krugersdorp. I worked there, I think, for 2 months. And then just after that, I moved on to the public sector, where I still am working even today, which is at Kopanong Hospital, the district hospital in Vereeniging, and I'm working in the accident and emergency department there. So, just to give you a little background about me, I actually matriculated in 2014. In 2015, I was a civil engineering student. I initially was very passionate about the field, and then I later on realized that I didn't feel a sense of fulfillment, a sense of direction, or a sense of giving back, if I would put it, in that field. So I think I completed a trimester or two, and right after that, I left that and then I moved on. I did computer literacy and office administration at a local college around my neighborhood, which is Protea Glen. I graduated from that, and then soon after that, I became a lecturer at the institution for the very same course that I was studying. And it was at that institution where I actually realized that my calling is medicine, or my calling is to be a healthcare worker, to be in the health field. I've always known this, but I've avoided it because the me, the the me who likes exploring, who likes being outside, really didn't want to be indoors every day of my life, going into a building, seeing patients. I didn't really picture myself doing that. But then it was during this course where I was teaching, and I was also learning in the process as a teacher, because I feel like when teaching, you also learn something new every time you're preparing a lecturer, or every time you're preparing a TAT or anything of that sort. You're learning because you need to constantly upgrade, constantly update information. Um, I really realized that I think I enjoy helping people. I enjoy listening to people. I enjoy figuring things out. In the same way, when you see a patient, you have no idea what's going on with them, and then you start to see them, you interview with them, you interview them, you engage with them, and it is through that conversation you gather information to actually help you to discover or unlock what the problem is. Also keeping in mind that we don't always know what patients have or what the problem is. So my role as a clinical associate in my workplace is we take history of patients, we interview patients, we examine patients, we do patient investigations as to get to an assessment of what the problem is or what the differential diagnosis are. We rule in, rule out information through that, and then you manage patients according to your assessment and the investigations that you did and information you gathered from that. And then we also initiate resuscitations. So I remember when I started working at Kopanong, I started just during COVID. It was very busy. We were short staffed. The environment was very intense. So it would get to days where you had to resuscitate patients on your own, and you had a senior maybe in another room also busy with the resuscitation. And that's where you actually learn and build your confidence and build your independence. Independence in the sense that you start being confident in making decisions. And then whenever you're not sure, you always have that someone, your senior, to discuss your patient cases with. And then what we also do as colleagues in casualty, as clinical associates in casualty, and medical officers in casualty, our jobs are very similar. We also assist in theater cases if there's C-sections. So this is mostly relevant when it's after hours. So anytime from 4 until 8 a.m. the next morning, from Monday to Friday, and on weekends, Saturday to Sunday, any time during that time. That's an after hour or an overtime, as most people call it. So if there is a case, emergency C-section, then we go to theater and we assist the surgeons with those procedures. Sometimes it's not C-sections. Sometimes it's surgical cases like surgical debridement, amputations, and so forth. And then also we rotate from the outpatient department to the triage department regularly, because all these three departments in the hospital I work in are linked together. So you get a sense of how you manage acutely ill patients and how you manage chronically ill patients who are a bit more stable than the acutely ill ones. And then we also do something called PSIs or M&Ms. So these ones are usually, you would be specifically selected by the clinical manager of the hospital to do an M&M. So what an M&M is, it's a morbidity and mortality meeting where a patient case is drawn either from a family member or a family that complained of the treatment that the patient received during their stay in the hospital, or because of a patient case where a patient died and there are things that should have been done that were not done, or there are also patient factors which are involved, or was this clinical factors which are asked the working staff, resources, and all those other factors which contributed to whatever outcome the patient case may have been. But most of these cases are cases that are interesting, cases that we all learn from. So that's why they are selected, and then you might be asked by a clinical manager to compile a presentation where in an M&M you'd be specifically presenting to your colleagues in the department, and the people involved in the cases who are either the clinical associate or the doctor who saw the patients or the nurses who are treating the patient, that information is kept confidential in an M&M. So we don't know who's involved. We just get a gist of the story of what happened, what went wrong, what could have been done differently, and what we can learn from that patient case. And then a PSI is the same as an M&M, but that one is it's different in the sense that you only present to the hospital management. And in that setting, all of the people who are treating the patient and seeing the patient, being the clinical associate, the medical officer, or the nurses involved, all of them are in there. So it's like a boardroom type of setting. And in that meeting, it's different in the sense that everyone is critiquing, everyone is asking questions, and it's basically like constructive criticism, if I may put it, where we all learn from the case through things that should have been done, which were not done, or mistakes that were there, or things that were done, which we should keep on doing. It's not always bad things. There are also good things, and also misdiagnosis. So that's where you also find out of other differentials you could have thought of based on the patient presentation and so forth. So this is just a gist of what I do here at Kopanong as a clinical associate. Moving on, my personal achievements. I've had several successful resuscitations, um, most of which I've done with myself and with the nurse. And then I'd have maybe a medical officer who might not necessarily always be there because we are short staffed, or they are also busy with another resource, or they are in theater assisting, or there's something happening which causes them to not be there. So it feels good to be able to save someone's life and know that you did it together with your team, be it was a team of nurses or other fellow clinical associates. And also the medical officers are there sometimes. But that was mostly during COVID where they were not there. But now, post COVID, most of the time they are there during resuscitations. But it was very good having successful resuscitations, and you still consider yourself a junior. And it's just, it was a big deal for me personally. And then I've gaining the trust of my colleagues and seniors. um, it was also a good achievement for me because initially when I started working in private, which was Pine Haven, actually for me, I feel like it was a bit different as compared to Mtandeni. For me, I found that it was a bit difficult for me to function in the private sector as compared to the public sector. And maybe it's because of the hospital that I'm in now and the fact that they are more familiar with clinical associates. So in private where I was the first clinical associate ever to work in that hospital. No one knew what a clinical associate was. They just desperately needed a clinical associate because it was during COVID. They were short staffed and the hospital was crowding. So that's how I ended up there. So it was a bit difficult for me to navigate in that setting because also as a student, I was never previously exposed to a private sector and how do I function there. So I had to navigate everything on my own. I had to teach them who I am. I had to teach them how I work. I had to teach them how to trust my skills and my knowledge, and that there are things that I can do. Because every time I tell them, when there's a patient, for example, coming in with a laceration, I'm like, oh, okay, I'll stitch that. And they look at me like, oh, you also stitch. And it was like a surprise to them to show that they actually didn't know anything about who I was and my function in the healthcare team. And then my other achievement was completing several courses, short courses, which really enhanced my skills and my clinical judgment. So I really agree with what the previous guest speaker was saying, Tandeni, that the more you read, the more you ask questions, the more you show interest in what you're doing, in who you are as a clinical associate, the more knowledge you'll get, and the more clinical judgment and confidence you'll get. You'll be able to make decisions on your own, obviously with the support of whoever is supervising you at that time when you're starting off. And then the more you work and the more you get exposed to the clinical field, the more comfortable even your senior will become to allow you to do certain things without them always being there. And for me, I remember when I was in private, my senior was always there because they didn't know what I was doing, and they were not 100% sure if I could do all of the things which are in my scope of practice. So with them seeing every day, with time, they started gaining their trust and started allowing me to do those things on my own, which was really, really great. Um, and then my challenges, constantly explaining who and what it is that I do. So I experienced this mostly in the first hospital I worked in, which was in the private sector. Um, and then having to prove my worth because they didn't know if really I could do all of the things in my scope of my of practice, and they couldn't really believe that you can do as many skills as we do and are exposed to as students in a set of 3 years. So that really gave them doubt that can you really do all of these things in just 3 years? And I told them yes, I could. Um, but the more I did these things, the more I showed them that, hey, I can actually put an IC drain, an intracostal drain. I can actually diagnose a pneumothorax, a hemopneumothorax, and treat the patient. I can actually do this and do that. That's the more they actually even became interested in the field and allowed me to practice fully in my scope of practice. And then the other challenge, which we're still facing even now, especially in the public sector, is we are very short staffed, and because of that you are very overworked. You get burned out and stressed out a lot because you end up doing so many things all at once, and things get overwhelming, and sometimes you see maybe 5 P1 patients and it's just only you. Some of these patients you need to transfer them, some of these patients you need to discuss. And with most P1s, there's like a certain time frame of seeing those patients, diagnosing those conditions and managing them, especially with patients who come in with things like CVAs and MIs, especially those type of patients, because time is everything for them. So when you have so many P1s and you get very overwhelmed and you get so stressed and all of that. So those are still challenges that I'm facing today. And then the last challenge is exploitation. So because you putting yourself out there and you showing these people that you can do so much and that you are so skilled, and you did all of those skills in just a set of 3 years, they end up putting a lot of responsibilities to you and a lot of tasks for you to do. And because of this, you end up doing things you're not really supposed to be doing. You end up being exploited in that sense. People end up actually doing things and leaving them for you to finish off. Like I'll make an example. Maybe if a fellow colleague who's maybe a medical doctor is seeing a patient, and then they maybe write the notes, they examine the patient, they diagnose the patient. And then when it's time for them to admit the patient, put the IV line, take bloods for the patient, then they'll ask you, can you please do this and this? And that's where you really should stand your ground and stand up for yourself. That's where you should really learn how and when to say no. There's certain things you should not tolerate, as much as you should be someone who's willing to learn, someone who puts themselves out there. You need to draw boundaries and draw the line so that people can, learn how to respect you as a clinical associate, irrespective of how much you earn or your job title or what you do. It doesn't matter. But I feel like that's where you really need to draw the line, because at the end of the day, you are not there to be a phlebotomist. You're not there to take bloods for people, put IV lines for them, or finish off whatever skills they are doing. It's different if maybe you are on call and someone is handing over a patient to you, and it just so happens that they haven't put up a line and it's time for them to knock off, but they've done everything else. That is different, so there you can take over the management and take over the treatment. But during a working time where everyone should be working and people are allocating things for you to do because you can do this, you can do that, at the end of the day, the workload is not shared equally. And that's also contributes to you being burned out, to you being so stressed and overworked and all of those things that I mentioned earlier on. So exploitation, it really is a thing, but you need to teach your staff how to treat you. Just like in anything in life, you teach people how to treat you. Moving on, my motivation for you is follow your calling and not your passion. Because I found that it is in your calling where you find true fulfillment. I say this because I was someone who was previously very passionate in engineering. And then later on, I realized that passion is just, it was for me, the passion I had was brewed on emotions of excitement, emotions of really wanting to build and all of those things. So it was purely just emotions, and there was no sense of direction or sense of knowing how it's going to turn out. Like in anything, we all don't know how anything's going to turn out. But for me, passion, I viewed it mostly, it was mostly based on my emotions at the time. And for my calling, because it was something I never really, really, really thought I would do, and something I was resisting for a very, very long time. Even when it was time for me to apply, there was something inside me telling me apply for health sciences, but I resisted and I was like, I'm going to be an engineer because I was so passionate about the field, only to find that I never felt as fulfilled in engineering as I do now in health sciences. As much as it's overwhelming and everything, but at the end of the day, when someone lives, I don't know, more years or more, yes, let me say more years, because we don't know actually what happens after the patient is discharged. But let's say someone lives more years because you saw them on that day and you examined them and you actually diagnosed that this patient is having an MI or a myocardial infarction, and you did something, you did investigations and you proved, you ruled it in that this patient is actually having an MI. And from there, you went on to actually treat that MI and you saved that patient's life. For me, it's something. It means out of the billions of people living on earth, I made a difference in one person's life, and that's fulfilling for me. And so that is why I enjoy this field so much. That is why I enjoy what I'm doing every day. As much as there's so many stressors and so many things happening, but the fact that you can make a difference on someone's life, it matters. And patients trust us so much. Patients trust healthcare workers so much, and when they ask you things and you tell them, some of them actually really do those things because they trust us that much. And also, my advice is be resilient. There's so many challenges in this field, specifically as a clinical associate. You will encounter people who are not for you, who don't understand what you're doing, who even feel that being a clinical associate is useless and worthless and you should just go on and study medicine. But this field does make a difference in the healthcare team. It's just unfortunate that government hasn't, put out as much posts out there for clinical associates to actually expose other hospitals like Pine Haven, for example, even though it's private, who didn't know much about clinical associates, on what a clinical associate is and what a clinical associate does, because it really does put the healthcare team together. It really does build the healthcare team, because everything we're doing, we working together as a team. So it's difficult. I won't lie, guys. It is difficult, but as much as it is difficult, it is also very rewarding in the end, because you do make a difference. You do practice your scope of practice as we are taught at school, and it is rewarding in the end. So being resilient through everything you'll go through is going to help you at the end to build that confidence, to learn how to be independent, to learn how to stand up for yourself, even when you are being exploited, and to actually say no, you know. And also discuss, and discuss. Never be arrogant. I also agree with the previous speaker, Mtandeni. Never ever be arrogant. Never ever think that you know everything. Medicine is an ever evolving field. Things always change. Things always are updated. Guidelines that we used 5 years ago for the same conditions are now different. Things are added, things are omitted, things are changed. So always discuss patients. And patients are not textbooks. You know, that's the other thing that I've learned. Patients are not textbooks. There are those patients who will come presenting with conditions that are not like common. They don't have common symptoms. They don't have common signs on examination. But when you actually do investigations for them, you find that they will actually have that condition which you are thinking of. But then, as you're asking the history and examining, it actually gets ruled out. So patients are not textbooks. It's not all common signs and symptoms that all patients will elicit. Some patients are different. Some don't even elicit anything. Some patients would be having a heart attack and not even perspirating, not even clutching their chests, not even complaining of chest pain, but they will be actually having a severe MI. And it is in you actually deciding to do the ECG to see that ST elevation or deviation that this person is actually having an MI, So I'd always say discuss your patients. You always have seniors, even senior clinical associates will assist you because they have more experience than you and they have more exposure to the clinical field than you. So they will give you advice based on maybe previous cases that they've seen or based on things that they've also learned practicing in the field. So it's not just the doctors that you get advice from, it's also your senior clinical associates, which in this hospital, we are very fortunate enough to have those people working in this hospital. Um, and then lastly, be confident. Is nothing beats confidence. Um, when you're confident, things happen. And sometimes you can't even explain how you did something, but it was just through your confidence. And I especially say this because I remember when I was apply for this post that I'm working in now, I was competing with clinical associates who were all of them were my seniors. And I remember there was one of them who had just completed her studies as a doctor, but she couldn't practice as yet because apparently it takes time because she did her degree in another country. So it takes time for them to process, for HPCSA to process your documents and everything. So I was competing with all of those people who are so experienced, who had more qualifications than me and more work experience than me, and who knew the clinical field much better than me. But I feel like my confidence is what made me get to where I am, because I didn't look at the obstacle and I didn't look at the challenges at that time and let the challenges defeat me or make me feel like I'm not good enough to get the post. But I would just tell myself, I'm going to be confident. I know what I know. And if I don't know something, I'm just going to be honest and be like, I don't know this, but I'm really willing to learn. And I feel like that's what's going to make you different from everyone else. Not pretending to be something you're not pretending to be a medical student or anything like that. Like, stay true to your ground. You're a clinical associate student. And when to graduate, you're going to be a clinical associate graduate. And be proud of that. Wear that badge. Even when patients ask you, who are you? When you explain yourself, fortunately these days we don't have enough time to actually explain to patients thoroughly who you are, what you do. But when you do have that opportunity, do explain to them so that they know who you are, so that they know that, you know what, they'll even say, there's that different doctor in that hospital. They don't know. They think everyone is a doctor who wears a stethoscope around their neck. There's that doctor, and every time I see that doctor does this and this, that doctor explains to me my condition I didn't understand before. Like, all the things you are taught at school, don't take them for granted, because it's those little things that will make patients actually remember you. It's you actually taking 5 minutes from your consultation and explaining what hypertension is and what that condition is doing to the patient's body and why the patient is having the symptoms that they're having, that will actually make a patient remember you. And that's what is going to even make you different from everyone else. And that's what's going to make you even build your confidence. Because next time you'll even hear your colleagues telling you, oh, Namba, there was this patient came here to thank you and was recommending you and all of that, just because of that 2 minutes, 3 minutes you took to explain something to a patient, or to even counsel a patient about something. Because patients, they don't know as much as they put out to know sometimes. And then lastly, my advice is to network and explore your options. It doesn't mean that just because you are in this degree or in this field, you have to end up in the clinical space. There are some of us who don't really like touching patients, who don't really, like talking to patients, but who enjoy being behind the scenes. There are clinical associates who are doing research, clinical associates who are in the corporate field and who are thriving and are happy in that. So explore your options. And when you do get the opportunity, network, speak to people, talk to people. Like, you must shake off your fear at this stage, and learn how to engage in people. You can even use having conversations with strangers or having conversations with your patients as an opportunity for you to develop your communication skills. Learn how to talk to people. You never know what one conversation might do for your life. You might have one conversation with one person and it might completely change your life and completely take you to new depths or new levels you never knew that you could reach. you know um yeah, that's it from my side. Thank you.
Thank you. Thank you so much, Nombasa. That is really, really so appreciated. You touched on so many things: identity in the clinical space as a clinical
Mm.
associate, and being confident as a clinical associate, forming networks, relationships, so many pearls of wisdom. Thank you, thank you, thank you so much. And I
Thank
hope
you.
everybody held on to quite a lot, and they'll hold on to that and move forward with it. So let us move to the last speaker of the session. So I'm going to briefly introduce you to Temoso. Temoso graduated from the University of Witwatersrand in 2006. He worked at Quality Health under the supervision of Dr. Lehote. He went on to work at Kopanong Medical Center. That's from 2018 to March 2020. He then moved to Uluvayo Medical Center in Fourways, or would it be, I don't know if I'm pronouncing it properly, Demo, so you must help me there. Um, and that was during the COVID pandemic times. And he then moved to Kalafong Hospital, of which the COVID center was dismantled after some time. He was then absorbed into the family medicine department in 2022, up until date. So we have someone who's also working in a district hospital, and we're keen to hear more from you. Thank you, Temoso.
Good evening, everyone. My name is Temoso Moseki. So yeah, basically, I graduated. I was just saying, this number really touched on everything that I would touch on, but I will talk about my experience as a clinical associate just to kind of share with everyone in terms of experience. So I graduated from VET in 2016. And then immediately after like 2 months of graduating, I got a job in Quali Health, which was like a private. So it was this primary healthcare clinic, which was started by a doctor. And then she really knew a lot about clinical associates. And she wanted to get us on board. So when I got there were two senior clinical associates that I used to work with. So it was a primary healthcare center with about 6 consultation. It wasn't like curtains, and then patients would queue outside, and then you'd see them in terms of their priority, and then you discuss with either the doctor or your seniors. Most of the guys I found they had already been working for 4 or 5 years, so they've worked in public sector, private sector, so they had a lot of experience. The work environment was very nice because of that, and I didn't have a lot of challenges regarding being known as a clinical associate, because I found people who had been going through the challenges for over years, and we navigated the space together. But I think the biggest challenge is always to try to, patients are gonna call you doctor, and you want to, especially the people that are interested, to explain to them that I'm a clinical associate, I do this, I do this, I do this. And sometimes that can create doubt in some other patients' minds. But generally, you need to be confident, like the first presenter and the second presenter said. The confidence is really your ammunition. Just the best way to remove that doubt from their minds is to be confident and know your skills, do a lot of ask a lot, especially when you started working. I used to ask with even the patients where I knew how to manage, I just consult. So I worked at Quali Health from 2016 to 2018. That's about 2 years. And for me, yeah, it was a very nice working environment. I just started doing the same thing over and over again, so I needed to grow. So I moved to Arana Medical Center. Arana Medical Center was also a primary health care, but it was more in a very big area, and we could do more. So I wanted to learn more, and I met these two doctors who had opened 3 primary healthcare setups, and I started working with them. At Aranang, it was a little bit different because it was outside of Gauteng. So you would get a lot of things. Like I went there to learn, obviously, but I got a lot more than I anticipated. You get primary health care, casualty cases, everything, like anything can come at any time. But the guys that I was working with there were very supportive, always be able to consult with them and discuss every patient. I grew up so much in that space. Just scared of out there. A lot of patients would come more for preventable diseases that you see these things could have been managed before, but because of the lack of proper primary health care in the whole area, you would get a lot of those that you'd have to cancel. You'd have to spend more time on the individual and contextual assessment, or the, how you used to call it, the social assessment and management of these patients. That was also really for me, because I really like talking to people, and I really like helping people from just to avoid a lot of problems. So that was a really nice experience in terms of that. And then during COVID, around 2019, 2020, early 2020, I moved on as well. And then I started working more of a local basis at private practice there was being run by a family physician in Fourways called Kuluvuyo Medical Center. I started working around March, April, and there we didn't see a lot of patients. The patients that would come, they were challenging. The biggest challenge there was the doctor wasn't on site those times, so I had to make a lot of decisions, and it's in Fourways, and it's very challenging. It's very challenging to run a medical practice in a very suburban area like that, because you get a lot of it is very challenging for me. I grew a lot clinically as well in that space, but quickly in November, December, I think it's December 2020, I got a job in Quali Health, in Kalafong Hospital during the COVID pandemic, where we had to work at the COVID. It was like a big COVID tent, and our responsibility there was to test and manage COVID patients and refer as appropriate. It was about 4 clinical associates, and then we were working with 2 medical officers. So each of us were assigned to 2 of us, each 2 were assigned to 1 medical officer. That was a very interesting working space because, as you guys can remember, COVID just came out of the blue. No one really knew. We knew it came in flu-like symptoms, but in terms of the hospital settings, as we know our people, they only come when things are really bad. So we used to see a lot of COVID complications. I learned a lot in the space, and it was a very cooperative space because it was COVID and everyone really didn't know how to manage COVID properly. And then so we were learning as we go. We used to attend a lot of webinars together. So that space really was very good. It was a very good space for a clinical association to be in because most of the challenges that I used to have in terms of not being known what I am and having to explain myself were not there. That space was just about getting there and helping patients, and there was a lot of work, but you were really appreciated. And then after that space, they dismantled, when COVID just kind of calmed down, they dismantled the COVID space, the COVID tent, and I got absorbed by the head of family medicine to work at the clinic. Out of the guys that I was working with at the tent, I was the only one that went inside the hospital and actually worked in family medicine. So that was the first challenge. So Kalafong is a tertiary hospital. It's a tertiary hospital. You have interns, you have a lot of interns, a lot of community service doctors, a lot of medical officers that are trying to impress and they want to specialize. And then you have registrars. Registrars are medical officers that are specializing. So as I was working in family medicine, the family medicine registrars and other registrars from other departments that were rotating. So it's a very competitive space in terms of clinical knowledge. People read books there. And I like what my colleagues said earlier on, that patients are not books, but at Kalafong, patients are books. So it's a very competitive space. You learn a lot, and you really have to be confident, but make it with the right amount of knowing when to ask, knowing when things are above your scope of practice, and knowing when to let other people do things, because we have medicine specialists, so there's always someone to do the work. But as we know, our healthcare system in South Africa is understaffed and there's so many patients, so there's always work. There's always a lot of work. So that has been a really growing space for me. I'm still working under family medicine in Kalafong Hospital, and for me, it has been the best working experience ever since I started working because of the learnings that I've got from working there. Yeah, I think that's about it from my side.
Thank you very much for sharing your story, Temoso. And also, it's nice to hear an experience from the public sector, especially at such a high level, the tertiary space and the dynamics of the tertiary space. So well done to you for thriving, because I know you're thriving in that space. What I'm going to do, because we're out of time, I'm going to choose questions and we'll have an answer from Mtandeni, if you're still around. I know he had to go at 7. Nombasa from yourself, and also from Temoso. So I'll read the questions that we have, and you can select any of these questions as we close off the evening. There was a question on salary. If you can jot down some of these questions, just to ask about salary in the public sector. There's a question about students who are confident in skill learning, be it first year, second year, third year. How can one be incorporated into the workspace as a student? But that was answered. Tandeni said that you just need a letter. You do need a letter from the institution to provide you so that you can volunteer. So it's accessible. In the hospital that you work in now, are there clinical associates or is there only one? I think that question was answered. At Kopanong Hospital, Nombasa did refer to her seniors, the senior clinical associates who were of assistance. To the speakers, do you think gaining additional research experience and conducting basic research at the training level would have influenced your current experience in the various clinical setting? Do you know if there are any CAs in the coastal areas, so Gqeberha, Durban, clinics or hospitals? If you have any knowledge, please do add something there. Okay, can we have the LinkedIn detail of all the speakers? Speakers, please can you maybe just leave your email address in the chat space so that if you consent, so that students and interested individuals can reach out to you, because I think the conversation can continue even after this space. So I'll start with Nombasa, and then I'll ask Mtandeni, then we can end with Temoso, just with brief answers. Thank you.
Okay, so I'm going to answer the salary question in a public setting. So it differs. It differs according to whether you are hired on a contract or whether you are hired as a permanent employee to that healthcare institution. And it also differs on what that hospital does for CAs. I'll make an example. In this hospital I'm working in now, clinical associates are allowed to do overtimes or calls and get paid for them. Whereas I know there are other settings or the other healthcare institutions around this area where I am, where the clinical associates cannot do overtimes or they cannot do calls. For example, I know of some clinical associates who are some of my friends who are working around the clinics in this area in Vereeniging, and they cannot do calls. Even though they are working in a 24-hour clinic, which has a casualty and that casualty functions in 24 hours. So I don't know if you want me to give you the numbers or you just want me to give you a range. I'm not sure, but it's different. What I do know is that if you are hired in government and it's under contract, you get paid more than someone who's hired permanent. That's because in as a clinical associate who's hired under a contract, you don't get those benefits that someone is getting who's permanent, which is the pension, and I think it's the GEPF or something like that. And medical aid and all those other deductions which they deduct on the money after tax. So because of that, it does influence how much money you do get at the end. So if you are permanent, you're getting a little bit less because you have pension fund and all those other things that you have to automatically the government does for you. And then if you are in the private, if you are in a contract, it's different. But if you are working, whether you're working in a clinic or you're working in a hospital, if you're a permanent clinical associate, you get paid all the same amount. Then it differs if you have medical aid or not. Then it will differ in that way. And then if you are on a contract, generally I know because I was on a COVID contract before I was hired permanently in this hospital, I was making more money than I am now because I have more benefits and as I mentioned.
Yes, well, that makes sense. Thank you, Nombasa. So it will vary, and also considering whether the benefits are present or not, it is going to vary. I think if there are further questions, we'll certainly leave email addresses.
Okay, in terms of research, in my space, I don't think so. But I do know some clinical associates that I went to school with that are now working in research full time. So after completing, they went and did their postgraduates in research, and they got jobs in research, and they're doing very well. And I guess that also answers the other question, that there are other clinical associates in Kalafong as well, but not in family medicine. There's other clinical associates in IOPD, which is immunology, which is basically HIV clinic. So these guys have done their courses in HIV and then they're working there. There's another clinical associate who works for Rural Health, RHI, but they're based at Kalafong.
Okay.
And then in the local clinics as well, there's other clinical associates. There's clinical associates working for COSAP, so they work in the clinics that are around the hospital that work in. So yeah, there's a lot of people around, clinical associates around me.
Thank you. Maybe one more, Temoso. Do you know if maybe some of the colleagues from your class, is anyone in Port Elizabeth or Durban, in the coastal areas?
Yeah, I know someone who's working in private in Durban, in Pietermaritzburg.
Oh, okay. Okay.
Yeah.
And
Okay,
then
and yeah, Durban as well, in town.
in town.
Yeah.
That's great. I know there are NGOs around Durban,
Yes.
Oram, which is quite nice to see the spread.
Yes, it is. And Oram is actually a nice space to work in.
Yes.
Yeah.
So thank you very much. I do want to thank you, Temoso, for taking off your time in your evening. Thank you to Nombasa. Thank you to Mtandeni. Just for being with us to give us that glimpse and that snapshot into your reality. And there is that balance that we have to be, keeping in mind that there are positives. And in each of the presenters' stories, I heard the positives, and there's also the challenges, right? That we need to bear in mind. And in the center of it all is to remember that we're there for the patient, and we're there to make impact, and the impact is observed, the impact is identified, the impact is felt where you guys are working. So it's really great to hear that. And the challenges are ongoing. We need to be able to address them, because nobody else is going to do it but us, and this community of practice that's actually growing. It's getting bigger and bigger every single year. So thank you very much. And we shall meet again next month, first Monday of the month. And we'll bring other senior clinical associates to come speak to the students. So thank you, everyone. Thank you for staying over 20 minutes. Do have a good evening. Bye-bye.